the ASMI has 3 modes on it. First one is the anti-spasm mode. When a spine has an injury, the facet joints classically send a distress signal to the paraspinal muscles here to go into a protective spasm. Now that could be a problem for a modern man, doesn't seem to be a problem for a caveman, and as it were, but this spasm can last for years sometimes, and then it's the spasm of these paraspinal muscles will itself squash the discs, causing like a feedback loop. It'll also mean the muscle, the paraspinals, really powerful muscles in the body, really big muscles in the body, every time they contract and relax, like every other muscle in the body, pumps up lymph, it pumps up venous blood back to the heart, and that's not happening when it's in permanent spasm. The whole area gets stagnant. And so the anti-spasm mode is about getting rid of that spasm, or reducing it. It's a mode that often makes the patient giggle. But if it's a very, very hot back, very, very sore, then I wouldn't do that over the actual bit if it's really, really sore to the touch. The next mode is the reflex mode. Along the spine there are lots of spinal reflexes, and what we do is the method of the ASMI machine is to start off with the anti-spasm mode, which we've just seen, and then hop between the mobilization mode and the reflex mode. And what that's doing is, and this is the reflex mode, and what's that doing is every time we do a little go on the mobilization mode to stretch the ligaments, we use the reflex mode to get the back to stimulate the reflexes. And it's those reflexes that kind of tell the back where it is, it tells the different vertebrae where they are, kind of wakes them up a bit. So like, oh, wait, come on, where are you? Wakey, wakey. And it kind of gets used to positions. So if you have an old injury, the back will think that's the position it should be in. We stretch the ligaments with the mobilization mode, and then we tap it with the reflex mode, and it kind of gets it to jump a bit and kind of, oh, actually, I should be here. And bit by bit by bit, this reflex mode helps the spine to basically jump a little bit by little bit back into its correct alignment. And of course this is the mobilization mode, which is sort of the workhorse, and then we finish the therapy with the anti-spasm mode, because sometimes it gets a bit tired and a bit tight, and then we often will, the patient will get them to stand up and see how they feel, and then sometimes we'll run while they're standing, occasionally if it's a bit tight, run the anti-spasm mode up and down the spine just to kind of loosen things up before they go home, as it were. To dry up a bit. Sometimes the oil dries up in the middle of therapy, so we stick a bit more on. So I use olive oil. Other people use like baby oil-esque type things. I find the extra virgin olive oil is a particularly good consistency, just about the right level of thickness. And you put it on, and then you get some paper to absorb most of it, so there's only just a little bit left. You don't want sort of big puddles of oil all over the place, because then that gets onto the pistons and ruins the pistons and shortens the life of the ASMI machine. So you just want something just to help it glide along so it's nice and comfortable for the patient. Within the three modes of the spasm, reflex and mobilization mode, there are different levels of power. So at the moment we're on medium power here. The power rating goes from 1 to 9, and that shows how many PSIs, pound per square unit inch, of pressure comes into these pistons. So to give you a visual of this, is power 1, very, very light, and it's a good place to start power 1. Especially on a new patient, and it's a good power to start on for the therapist as well when they're learning. So you get to learn the technique, and you can start to feel the pistons, the vertebrae moving underneath the pistons. And it's just a great feeling when you have somebody in with a bad back, and you can just feel, it feels like sometimes the vertebrae feel like a cranky old door with a hinge, and it feels like it just moving a little bit. It hasn't moved in a long time. And the patient gets up and you go, wow, you know, I feel a million times better. Which when you're feeling, so you know, it's join in with the therapy in terms of it is a machine, but you use a lot of palpation techniques through the machine to feel the vertebrae, and in terms of where the vertebrae is going and what's coming up next for the vertebrae. You sort of use your fingers and you press down the fingers and you just go either side of the spine. You kind of feel the dips and the curves and the twists and where the spine's going. But even if somebody doesn't have classic scoliosis, there's an awful lot of people with vertebrae twisted in and out of shape. In fact, there's a lot of people who have a vertebrae here that goes that way, one that goes that way, one that goes that way, here, and overall it's reasonably straight. But had they all been going in the same direction, twisted out of shape, they would have quite a bit of scoliosis. And so, you know, you classically will untwist that, untwist that, untwist that, and get it straight. But actually, you get the same technique with scoliosis generally, where even if it goes, you untwist it, untwist it, untwist it, untwist it, untwist it. Scoliosis is a broad topic, and some vertebrae out of shape. It takes longer to sort of regrow, but generally that's the idea. These things are classically, usually trauma injuries, and they have this routine whereby you relax the muscles either side, you get the vertebrae to tight ligaments to stretch a little bit, and then you tap it through the reflex mode, get it to jump back into finding its better place, and then you repeat a few times and the patient gets better. So starting off on power 1. The other thing is I've been working here wide, as it were. I can work narrow. When you work wide, you're generally stretching ligaments from one vertebrae to the next. When you're working narrow, there are ligaments which jump over a vertebrae, and there's a few ligaments that jump over 3. The power machine will pick up, going narrow, ligaments that need stretching over 2 that jump one vertebrae, so there's between 2 vertebrae, miss 1 vertebrae. It's probably not wide enough, long enough to do 3, but the 2 generally get, 1 and 2 generally get the back fix. So I'm going to do narrow. You start off generally wide, and then you will move on to narrow and finish off on wide. That's a general thing. Just here we go. Grab the vertebrae. Now often, for the first few, I grab it and let it ride, and I get to see what's happening. First of all, it's like you go to the gym and you do a couple of stretches, and you're very cranky and very stiff, and then a few seconds later you'll do another stretch, and suddenly you're able to stretch a lot more. All the back, the ligaments in the back work a bit like this. So the first few, it's no bad idea just to grab it and let it rise. In fact, that's not a bad technique for all therapy, to grab it and let it rise. But as a more advanced therapy, but also one that you need a lot more skill for, is you sort of like, having grabbed it, having let it rise, while the pistons are full, you give it you press down on those just before the pistons release their power, and as they're releasing the thing, you give it a press down, and see you've got the vertebrae, you pin them down so they're not going to kick up, you stretch them out a little bit, and then you give them a final stretch down, and that can also be very, very therapeutic. But the vast majority of patients, you could just basically grab, rise, let it end, let it empty, grab, replace, grab, rise. I don't know how clear that comes up in the video, but here we go. It's going to move to power 2 now. You can hear the tonality, drop a note or 2. There's a sort of a rhythm whereby, in terms of how the therapist feels it working, it's a bit like one of those old arcade games where the automatic hand comes over and picks up a toy or whatever and moves it over and drops it into the bucket, or doesn't, as it usually does. And you feel like with these pistons rising, it feels like you're grabbing the vertebrae and grabbing and controlling it, and then you kind of rise up. So you sort of have got at the point at which the 2 pistons come down like that, and then the other 2 pistons come down the opposite way. So 2 pistons come down, like that, and then they come down like that. And we operate on the back that way and that way. And the very initial thing that the pistons, right at the beginning, the pistons are down and have no air in. And as the pistons get a little bit of air in, you have pressure from yourself on the vertebrae here and here, or here and here, and just for a nanosecond you sort of maintain that pressure and that movement, and that just allows those two vertebrae just in a micro way to sort of engage with the vertebrae, these two pistons to engage with the vertebrae, sort of grab hold of it, and then you rise up, you allow the pistons to rise up. Now, the way you do the rising of the pistons, if you don't do it exactly how the pistons come up, so if they come up like that, you don't just kind of rise up as if you have no pressure on them. You maintain pressure on them, but you let it rise. So in terms of force, the pistons are essentially pushing down like that, and so they're pushing down on the pistons, the pistons are pushing down the vertebrae like that. But if you put some force on top of that, then it's sort of like, it's as if, I don't know, in terms of numbers, pistons are pushing down with power 5, as it were, in basic numbers, and you're rising up at power 3, and the net effect on the vertebrae is power 2. And it's the net effect after you've sort of pinned down the vertebrae, you rise up with them a bit. So you don't want, one of the things that happens with the vertebrae that's had damage and it's been shunted out of place by trauma injury is that were a nice, a normal, healthy line vertebrae move like this, just nicely. The ones with it being jammed up against each other, they're often out of place a bit. Facet joints jammed together, all that malarkey. And so when they go like this, they'll, if you allow them to, they kind of do funny twists and kick up, and which is something you don't want. And what we're trying ultimately to do, despite it being called a vertebral mobilizing technique, it's probably a better description to say we're trying to do a ligament stretching technique. The ligaments, the intervertebral ligaments, are the side of holding the ligaments together, holding the vertebrae together, that you really, when the one's short and tight, what we're trying to do by these movements is give it a little stretch and get it out of that tight knot and give it a bit, it might be a very old injury, so it might actually be short. And so we don't really, so there's often times we don't really want a big movement of the vertebrae. We don't want a big mobilization because they do funny things and kick up. So it's sort of like a pin down, control, rise up. And how do you learn that technique? You learn that technique like any other technique, starting on low power, and as you sort of get to feel what's happening under you and get to see different backs, you use more power as appropriate when the back wants it and when you're ready to do it. So that's how you learn. And even on every patient, it's a great idea to start on a very light mode and then see how that patient is today, because you might have treated the patient a few weeks ago and their back is all nice and in one mode, and you might have had a bad couple of weeks since then in terms of the back, and it might not be ready for you to pick up exactly where you left off. Now let's start again on low power and build up. This is remarkably good at fixing really bad backs really quickly, but it's quick enough anyway, you don't need to do it at 1,000,000 miles an hour. Always start on low power, see how the back responds, build up, talk to the patient a lot, see how that's feeling, today. And so it's not meant to be painful with a capital P. Occasionally you get a little touch of pain, a sweet pain now and again. If it's really tight, it just releases, but it's not meant to be in any way sort of painful. So that's what we are doing here.